Hi, hello, good afternoon. We are coming to you live from the University of the Philippines, Manila for the 19th Lourdes Manahan Lectures in Rheumatology. I am Dr. Michael T., a professor of medicine from the Division of Rheumatology. I would like to first thank our sponsor, Mega Pharmaceuticals, for their participation and support for this webinar. To all our participants, I'd like to thank you for joining us today. If you have any questions, you can place them at the Q&A box, and we will address them during the open forum after the lecture. You will receive your certificate of participation to this webinar a week after you submit the evaluation form and the post-test. The link will be posted at the Q&A box and at the chat box midway through the webinar. Today, we are holding the first of our 8-part LMLR series for this year. The Lourdes Manahan Lectures for Rheumatology series hopes to continue the advocacy of teaching rheumatology to our colleagues, as initiated by the first Filipino rheumatologist, Dr. Lourdes Manahan. LMLR is being conducted in support of Sustainable Development Goal number 3, Health and Well-being, and SDG Quality Education of the World Health Organization. The Division of Rheumatology is also happy to announce its publication of the Atlas of Rheumatic Diseases in the Philippines under the leadership of Editor-in-Chief Professor Esther Penserga. We hope this book becomes a local reference on rheumatology for our students, fellow physicians, and other healthcare professionals interested in the care of patients with rheumatic diseases. For those who wish to avail of the book, please email pgh.rheumatology@gmail.com, which is posted now, or text message to the number posted here, 0925-808-3573. This first lecture of this year's LMLR will focus on the optimization of rheumatoid arthritis management during the COVID-19 pandemic. We are honored to have two distinguished speakers this afternoon. Our first speaker is Dr. Cherie Cervantes. She is a clinical associate professor at the UP College of Medicine and was the previous division chief of allergy and immunology at the Philippine General Hospital. She is the vice chief and training officer of allergy and immunology at the Asian Hospital and Medical Center. Dr. Cervantes has published numerous researches and is a member of the editorial board of the Philippine Journal of Allergy, Asthma, and Immunology. Our second esteemed speaker is Dr. Jose Paulo Lorenzo. He is a clinical associate professor of the Department of Medicine, Division of Rheumatology, and is currently the vice president of the Asia Pacific League of Associations for Rheumatology, or APLAR. He is a current chair of the Department of Medicine, Makati Medical Center, and is an active consultant at the Asian Hospital and Medical Center. Ladies and gentlemen, let us welcome Dr. Cervantes and Dr. Lorenzo as they share their expertise in today's lecture. Good afternoon.
Thank you for that kind introduction, Dr. T. Good afternoon, everyone. I would like to thank the Division of Rheumatology for inviting me to give a lecture this afternoon on COVID-19 immunology and vaccination among patients with rheumatic diseases. It is truly an honor to be invited to the Lourdes Manahan Lecture Series. If I remember correctly, I was still a resident when the division started this. The title of this webinar is RA Management in COVID, but for my part, I have been tasked to broaden my scope to include autoimmune diseases in general, their mechanisms and how their treatment options affect the immune system and susceptibility to COVID-19. Then, we will discuss the efficacy of safety of vaccination in this population. COVID-19 does not only cause respiratory illness, but also leads to an uncontrolled inflammatory response and hypercoagulation through activating both the innate and adaptive immune system. It is very important to evaluate the outcomes of COVID-19 in patients with rheumatic diseases. Why? Because first, patients with rheumatic diseases are vulnerable given the background of dysregulated immune response and the use of anti-rheumatic drugs with different degrees of immunosuppression. An exaggerated immune response may occur following an acute viral infection, for instance, the uncontrolled type 1 interferon activation in patients with SLE. Second, multiple cytokines have been involved in the pathogenesis of severe COVID-19. A meta-analysis on clinical outcomes of COVID-19 in patients with rheumatic diseases involving more than 1,000 patients showed that the overall rate of hospitalization of rheumatic patients is 58%. Europe has the highest proportion of patients requiring oxygen support, and note that the overall fatality rate of 7% is double of that of the WHO database for COVID-19 patients. Results from the COVID-19 Global Rheumatology Alliance Registry have shown that among patients with rheumatic disease, COVID-19 related death was associated with known general factors such as older age, male sex, and specific comorbidities such as hypertension with cardiovascular disease and chronic lung disease. Disease-specific factors such as disease activity and a steroid requirement of more than 10 milligrams per day equivalent of prednisolone was also associated with higher odds of death. What is the pathophysiologic mechanism behind these? Like other viruses, SARS-CoV-2 requires entry into cells in order to replicate. This in turn results in cellular responses aimed at quelling the viral infection. The primary cellular receptors for SARS-CoV-2, which bind the viral spike protein, is angiotensin-converting enzyme 2, or ACE2, and its co-receptor, transmembrane serine protease 2, or TMPRSS2. Patients with comorbidities for cardiovascular disease, including obesity, hypertension, and chronic kidney disease, have higher levels of circulating ACE2. These patients have been shown to have more severe COVID-19. These comorbidities are present more frequently in patients with rheumatic diseases. Interestingly, both ACE2 and TMPRSS2 are transcriptionally expressed at higher levels in respiratory epithelial cells in elderly patients. ACE2 is also hypomethylated and overexpressed in patients with lupus. Apolipoprotein E, a known inducer of ACE2, is present in higher levels in patients with rheumatic and cardiovascular diseases. This suggests that ACE2 levels are likely elevated in rheumatic patients. This theoretically increases the risk of contracting COVID-19 in patients with rheumatic diseases. Also, cytokines that are elevated in patients with rheumatic diseases like TNF-alpha may promote the expression of ACE2, and disease-modifying therapies may reduce their expression. This suggests that maintaining adequate control of rheumatic diseases may be important in reducing the risk of infection. This notion is supported by recent data from prospective cohorts showing that the incidence of COVID-19 infection in patients receiving disease-modifying therapies, such as TNF-alpha inhibitors and JAK inhibitors for inflammatory conditions, was comparable to that of the general population. There are similarities between SARS-CoV-2 infection and rheumatic diseases such as SLE, Sjogren's syndrome, systemic sclerosis, and systemic juvenile idiopathic arthritis, in that they both have a reduction in NK cell function, ultimately leading to the hyperinflammation and organ dysfunction from cytokine release. SARS-CoV-2 directly suppresses NK cell function through binding of ACE2 receptors on the cell surface. This reduces NK cell ability to kill both viral infected cells and activated immune cells, increasing the production of pro-inflammatory cytokines, contributing to the development of hyperinflammation. Note that IL-6 reduces NK cell cytotoxicity. Similarly, in rheumatic diseases, you have an unknown antigen binding to a naive T cell via an antigen-presenting cell, producing activated immune cells. In rheumatic diseases, dysfunctional NK cells are not effective at clearing the immune cells, leading to the production of the same pro-inflammatory cytokines like interleukin-1, 6, interferon gamma, and TNF-alpha, which ultimately leads to organ damage. Again, interleukin-6 reduces NK cell cytotoxicity in rheumatic disease, just like in SARS-CoV-2 infection. So patients with rheumatic diseases, especially SLE, may be at an increased risk for COVID-19, particularly if their diseases are not adequately controlled. And with the unbalanced immune response in COVID-19 patients with vascular comorbidities, COVID-19 infection may also lead to an underlying flare of rheumatic disease. This is most likely in disease subsets of inflammatory arthritis and ANCA-associated vasculitis, where the exposure to viral infections has been shown to predispose these patients to disease flares. It is well established that coagulation is intricately linked with inflammation, particularly as elevated IL-6 levels and CRP may be associated in promoting the formation of thrombosis. SARS-CoV-2 also activates the complement system, an integral part of the component of the innate immune response. The complement cascade can be activated by 3 different pathways: the classical, the lectin, and the alternative pathway that promote thrombosis. Like patients with COVID-19, patients with uncontrolled rheumatic diseases have increased risk for thrombosis. This is most notable in patients with SLE, although it has been described in patients with ANCA vasculitis and Sjogren's syndrome. The thrombotic risks appear to improve once the diseases are more quiescent, although persistent and increased hypercoagulability has been demonstrated in patients during disease remission and may be associated with the activation of the alternative pathway and netosis. Corticosteroids are commonly used in patients with rheumatic diseases, but they may increase the risk of contracting COVID-19. Corticosteroids, particularly at increased doses, reduce the innate cell-mediated and humoral immune responses to infection and increase the risk of opportunistic infections. Prednisone at doses of more than 10 milligrams per day was associated with increased COVID severity and among patients with rheumatic diseases. It is not clear if the increased risk is conferred from corticosteroid use or from the dysregulated immunity stemming from the activity of the rheumatic disease. Regardless, corticosteroids increase the risk of secondary infections. But it has been postulated that acute corticosteroid use in patients with a cytokine storm related to COVID-19 may be beneficial. The recovery trial demonstrated the beneficial effect of dexamethasone in lowering mortality among those who were receiving either invasive or mechanical ventilation or oxygen alone. So it is important to weigh the potential benefits, like treating the severe cytokine storm in COVID-19 or the inflammatory component of rheumatic diseases in the acute setting, with the risk of infections, with the risk of use of long-term corticosteroids. According to the COVID-19 Global Rheumatology Alliance Registry, rituximab, sulfasalazine, immunosuppressants such as azathioprine, cyclophosphamide, cyclosporin, mycophenolate, or tacrolimus, and those not receiving any disease-modifying anti-rheumatic drugs or DMARDs were associated with higher odds of death compared with those on methotrexate alone. If we only look at patients with rheumatoid arthritis, the GRA has found that people treated with rituximab or JAK inhibitors like baricitinib had worse COVID-19 severity than those with TNF inhibitors like infliximab or adalimumab. Why is this so? Rituximab binds to CD20 on the surface of B cells, effectively depleting this cell type, and it interferes with antibody development because it is the B cells that activate the plasma cells to produce the antibodies. So B cell depletion could potentially compromise antiviral immunity, including the development of SARS-CoV-2 antibodies. The association between rituximab and COVID-19 related death could have been influenced by the typical co-administration of methylprednisolone with rituximab. That study lacked details regarding the timing of rituximab exposure in relation to the COVID-19 infection or the duration of B-cell depletion at the time of infection, which may be particularly relevant when considering the risk of a poor outcome following rituximab exposure. It is also possible that glucocorticoids given as a pre-medication to rituximab infusions may have contributed to the increased risk of poor COVID-19 outcomes in patients with rheumatoid arthritis being treated with rituximab. In an international registry of patients with inflammatory bowel disease and COVID-19, the use of sulfasalazine was associated with severe COVID-19 with an odds ratio of 3.1. This finding is surprising because sulfasalazine is usually considered to have a low immunosuppressive effect. In the study of the Global Rheumatology Alliance, the association of death and sulfasalazine was limited to previous or current smokers. The findings of COVID-19 GRA are of particular interest with regard to JAK inhibitors. In the general population, baricitinib may improve outcomes for patients with COVID-19, but the GRA study observed worse outcomes associated with the baseline use of JAK inhibitors. They made a parallelism with glucocorticoids, which are known to have benefits when initiated for moderate to severe COVID-19, but are also associated with worse outcomes among those on baseline glucocorticoids at the time of infection, although this may be explained by residual disease activity. So the timing of JAK inhibitors relative to the COVID-19 disease course may explain these findings. And just like glucocorticoids, the baseline use of JAK inhibitors at the time of SARS-CoV-2 infection may enhance viral replication and dampen a healthy immune response, while the initiation of JAK inhibitors at clinical deterioration may dampen an aberrant systemic inflammatory response. So alternatively, there may be relevant differences in COVID-19 outcomes depending on the type of JAK inhibitor used, like tofacitinib, baricitinib, upadacitinib. These target different genus kinases. Now that we already know the immune dysregulation that happens in COVID-19 infection among patients with rheumatic diseases, the next question is, how effective and how safe would vaccination be for them? There are some hypothesized modifiers of vaccine response and considerations in patients with autoimmune inflammatory disorders. Elderly patients may have diminished immune reactivity and reduced seroconversion rate because of the long-standing autoimmune inflammatory disease with its confounding effect. Male gender may be associated with a lower acceptance rate and lower rates of post-vaccination conversion. Immune printing, because of a previous coronavirus exposure, may affect the vaccine effectiveness both positively or negatively. Obesity and end organ damage may affect host response to vaccines due to altered T cell function and reduced levels of interferon gamma and granzyme B. The long-standing and active autoimmune inflammatory disease may affect immunogenicity by reducing seroconversion rates. B-cell depleting therapy like rituximab decreases B-cell responses, and thus a serological response to vaccines are hindered by these. High-dose glucocorticoids and other immunosuppressive agents have a variable impact on vaccine effectiveness, with the majority of patients having satisfactory seroconversion rates. The main issues that need to be addressed about vaccines and patients living with autoimmune disease are, will vaccines be sufficiently effective while on immunosuppressive treatment, and could vaccines cause an autoimmune inflammatory disease flare? This is a very nice diagram on how mRNA and adenoviral vector vaccines work. mRNA vaccines contain mRNA encoding the SARS-CoV-2 spike protein, which is the viral receptor viral receptor binding domain that recognizes and binds to the host receptor ACE2. The mRNA vaccines are unique in that they use the antibody's existing immune pathways to produce an immune response similar to that of a natural viral infection. And when the vaccine is delivered, the mRNA is taken up by the host cells and used by the ribosomes to produce spike protein. This happens for a finite period of time before the mRNA is quickly degraded. The spike proteins can then be recognized and presented by the cells via the major histocompatibility complex class 1 molecules, just as would occur with other endogenously produced antigens in a natural viral infection. This elicits a robust CD8 and CD81 and CD41 T cell mediated response that ultimately leads to the creation of memory T cells and B cells and the production of neutralizing antibodies against the spike protein. Adenoviral vector vaccines like AstraZeneca use a recombinant virus that is unable to replicate but is still capable of entering human cells. Once within the host cell, the SARS-CoV-2 spike protein antigen is expressed, resulting in the host generation of a T cell mediated immune response, stimulating the B cells to produce neutralizing antibodies. So patients on B cell therapies have a decreased capability of producing these neutralizing antibodies against the SARS-CoV-2 virus. In addition to presenting antigen as the target of the immune response, vaccines must also contain an adjuvant that activates the innate immune system and provides the necessary second signal for T cell activation and the generation of a robust immune response. For mRNA vaccines, the mRNA both encodes the antigen and acts as an adjuvant. Upon entry into a cell, single-stranded RNA activates endosomal toll-like receptors, including TLR3 and TLR7. Both single-stranded RNA and double-stranded RNA activate the inflammasome in the cytosol. And these trigger an inflammatory response in the generation of type 1 interferons, which are known to flare autoimmune diseases. However, vaccine developers have implemented modifications to reduce interferon activation and reduce the risk, including the addition of stabilizing adjuvants and removal of interferon-stimulating double-stranded mRNA from final preparations. Adenoviral vector vaccines also function as adjuvants. The double-stranded DNA inside the viral vector both encodes the spike protein antigen and induces the production of type 1 interferons via the activation through TLR9. In addition to the concerns about potentially flaring inflammatory disease via the production of type 1 interferons, some inflammatory diseases are associated with an increased risk of thrombosis. Adenoviral vector vaccines carry a rare but increased risk of thrombosis with thrombocytopenia, potentially due to the production of autoantibodies to platelet factor 4. Thrombosis has occurred 1 to 2 weeks after vaccination, mostly in women and primarily in the cerebral venous sinus. Several consensus statements have been published by international and local rheumatology societies with regard to vaccination among patients with rheumatic diseases. These are from the American College of Rheumatology, the Asia Pacific League of Associations for Rheumatology, or APLAR, and our very own Philippine Rheumatology Association. And I'm very proud to say that several of our distinguished faculty members have been part of these expert panels. All consensus statements are in agreement that patients with rheumatic diseases receive the COVID-19 vaccine as soon as it becomes available to them. In the United States, the ACR recommended using an mRNA vaccine. How about inactivated vaccines like Sinovac? The 2013 IDSA CPG specifically recommends that patients with chronic inflammatory illness treated or about to be treated with immunosuppressive agents be administered inactivated vaccines, including the inactivated influenza vaccine, as immunocompetent persons are vaccinated. So we have discussed that the immune response of rheumatic disease patients to the vaccine isn't as good as that of the general population. And because of this, the ACR recommends a third dose, which is a supplemental dose for these immunocompromised patients. For this third supplemental dose, the ACR recommends using an mRNA vaccine as well. And aside from a third dose, they also recommend a fourth dose, which they call the booster dose, since these patients are immunocompromised. These 4 doses, the primary, supplemental, and booster doses, should be given to all RMD patients, whether or not they have been infected with COVID in the past. Routine checking for immune response, like checking for antibodies, is not recommended. Even after vaccination, all public health guidelines should still be observed. Since these patients are at risk for poor outcomes, they also recommend giving pre-exposure monoclonal antibody treatment, either as prophylaxis or as treatment. The household members of these patients should all be vaccinated to provide them with the cocooning effect to protect the immunocompromised patient. Again, these patients should be vaccinated as soon as it is available to them. The 3 rheumatology societies have come up with recommendations about the timing of vaccination with regard to the administration of various immunomodulators, as shown on this table. For hydroxychloroquine and IVIG, no modifications are required. If disease activity allows, immunosuppressive therapy should be initiated in patients with newly diagnosed RMD at least 2 weeks after the completion of SARS-CoV-2 vaccination, with the minimum recommended interval between 2 successive vaccine doses, in order to allow the immune system to mount an adequate immune response to the vaccine, and also to minimize the delay in the administration of immunosuppressive therapy. The PRA recommends withholding methotrexate, cyclophosphamide, and JAK inhibitors such as baricitinib for 1 week after vaccination. The APLR's recommendation for methotrexate is to withhold it for 2 weeks if the disease is stable. The APLR also recommends that immunization schedules for other vaccines like flu, pneumonia, etc. should be maintained. So in summary, patients with autoimmune and inflammatory rheumatic diseases are at greater risk for hospitalization, worse COVID-19 outcomes, and mortality than the general population. This is due to disease and treatment-related factors. COVID-19 and autoimmune diseases have similar immunopathologic mechanisms, triggering almost the same cytokines. B-cell therapies decrease antibody production, so patients on rituximab are unable to produce the necessary antibodies to SARS-CoV-2. And because of these, patients with rheumatic diseases should be prioritized for vaccination. Aside from a possible allergic reaction to those who have a history of allergies to any of the components of the vaccine, there are no known additional contraindications to COVID-19 vaccination. This is best administered when the disease isn't in flare. The expected response to vaccination is blunted in magnitude and duration, so the ACR recommends a 3rd and even a 4th dose of the vaccine. There is a theoretical risk of flare of the rheumatic disease, so post-vaccination monitoring is very important. But nevertheless, the bottom line is that for patients with autoimmune and inflammatory rheumatic diseases, the benefit of COVID-19 vaccination for RMD patients outweighs the potential risk for new onset autoimmunity. So this is my last slide. Thank you very much for your kind attention. I would be happy to answer any questions that you might have after the lecture of Dr. Lorenzo. Thank you.
Good afternoon. I'd like to thank the organizers of the 19th Lourdes Manahan Lectures in Rheumatology series for inviting me here today to give you a talk on rheumatoid arthritis management during COVID-19 pandemic. The objectives of my talk are to discuss guidance in the management of rheumatoid arthritis during the COVID-19 pandemic and to present vaccine guidance in rheumatic and musculoskeletal diseases. To give a brief overview of the COVID-19 pandemic historical events, the first reported cases in Wuhan, China were done on December of 2019. The first reported case in the US, January 21 of 2020, while the first reported case in the Philippines was on January 31, 2020. COVID-19 was declared a pandemic by the WHO on March 11 of 2020, and the FDA granted emergency use for hydroxychloroquine for the treatment of COVID-19 on March 30 of 2020. April 11, the following month, the ACR COVID-19 clinical guidance for adult patients with rheumatic diseases was published. In June, the EULAR provisional recommendations for the management of RMDs was also published. The first surge in the Philippines took place in August 11 of 2020, and the first COVID-19 vaccine rollout in the world was with the Pfizer vaccine on December 14 of 2020. The first COVID-19 vaccine rollout in the Philippines, or Sinovac, was on March 1 of 2021, and the ACR guidance for COVID-19 vaccination in patients with RMD version 1 was on March 17, 2021. The Philippines is currently on its fourth surge at its tail end. So for rheumatoid arthritis, remission is still the main target of treatment. Treat to target strategy is in play, and disease improvement is the goal. So for active RA, the main target is remission, and you adapt therapy according to disease activity, and you use composite measure of disease activity every 1 to 3 months with remission criteria, the DAS28-ESR, DAS28-CRP, the CDAI, SDAI, and the Boolean criteria. If you're not able to sustain remission, then you have to adapt therapy and you try to achieve remission again. If that is not possible, your alternative target is low disease activity. And if you're not able to maintain this, you have to adapt your therapy and you assess disease activity every 3 to 6 months. Pharmacologic treatment for RA basically remains unchanged. Your NSAIDs, your corticosteroids, conventional synthetic DMARDs, methotrexate, leflunomide, sulfasalazine, and your antimalarial hydroxychloroquine. And your biologic DMARDs and your targeted synthetic DMARDs, your JAK inhibitors, tofacitinib and baricitinib. For the biologic DMARDs, what we have in the Philippines are your TNF inhibitors, etanercept, infliximab, adalimumab, golimumab, and your IL-6 inhibitors, tocilizumab. And we also have the anti-CD20 or anti-B cell rituximab. So I looked at the COVID-19 Global Rheumatology Alliance Provider Registry, which reported cases of COVID-19 that had concurrent rheumatic and musculoskeletal diseases. And this is data from information from August 2 of 2021. I show this world map because I'm very happy and proud to note that the Philippines is reporting or contributing to this registry. So out of 10,117 patients, rheumatoid arthritis was the most commonly reported, with 40.92% of the 10,117 patients. The most common age was of acquiring COVID-19 and a rheumatic and musculoskeletal disease was the age of 50 to 65 years. And the women were the most commonly affected with 76.75%. For race or ethnicity, I highlighted others because this is where my fellows have informed me that they put our Far East race and included this in the registry. Looking at the medications prior to COVID-19 diagnosis, these are all the medications mentioned above for the treatment of rheumatoid arthritis. 64% were on conventional synthetic DMARDs, whether in monotherapy or combination therapy. And in our country, we have methotrexate. Biologic DMARDs, your JAK inhibitors, your antimalarials, your NSAIDs, and your glucocorticosteroids. So if you notice, 33% of the patient population was on glucocorticoids. So what happened to these patients? 90% of them resolved COVID-19 infection. 5% of them had unresolved COVID-19 infection at the time of reporting of the case, and 3% was unknown. For the ventilation status of these patients, 59%, or the majority of them, were not hospitalized and no supplemental oxygen was needed. 12% required supplemental oxygen or non-invasive ventilation. 4.48% required invasive mechanical ventilation or extracorporeal membrane oxygenation. And ventilation was required, but the type was unknown in 24%. And death occurred in 5.3% of this population of 10,000. And 29% or almost 30% were hospitalized. So from the data that was generated by the Global Rheumatology Alliance, COVID-19, associations of baseline use of biologic and targeted synthetic DMARDs with COVID-19 severity in rheumatoid arthritis was reported by this group of authors, many of them, a big number of authors in this group. So what is already known about this subject? A previous study of the COVID-19 Global Rheumatology Alliance suggested that people with systemic rheumatic diseases on biologic or targeted synthetic DMARDs had lower odds of hospitalization than those not using DMARDs. And previous studies reported that people with systemic rheumatic diseases using rituximab had higher odds of COVID-19 related mortality than those using alternative DMARDs such as methotrexate. So here are the baseline characteristics according to the use of biologic or targeted synthetic DMARDs in RA at the time of COVID-19 onset. For the demographics, the mean age overall was 56 years. The majority were female, and there were a few Far East Asian persons in this group. The different biologics in use were your abatacept, rituximab, IL-6 inhibitors, JAK inhibitors, and TNF inhibitors. And you can see that the majority were on TNF inhibitors, followed by your JAK inhibitors. The frequency and proportions of outcomes in the COVID-19 severity scale according to the baseline use of biologics and targeted synthetic DMARDs with RA at the time of COVID-19 onset. So the different parameters that were looked into were for the severity scale were those not hospitalized, those who were hospitalized with oxygen, those hospitalized with any oxygen or ventilation, death, and death. So overall, you could see that 78 0.6% were not hospitalized, and that death occurred in 5.5% of these patients. And the highest percentage of patients who were treated, who died, were those treated with rituximab. That was 14.8% of patients with on rituximab. And this was followed by the JAK inhibitors that had about 7.1% of patients taking them prior to the onset of COVID-19 infection that died. So the same outcome using the COVID-19 severity scale, same COVID-19 outcome as in the previous table. And this measures the odds ratio of biologic or targeted DMARDs and the severity scale. And you can see that with rituximab, the odds ratio is much higher across all outcomes than the other medications used, JAK inhibitors, IL-6, and abatacept. And your TNF inhibitors were used as a reference range. You would also note that after rituximab, it's the JAK inhibitors that have a higher odds ratio of all these outcomes. So the main findings of this study are 78.6% of RA patients taking biologic or targeted synthetic DMARDs at the time of COVID-19 diagnosis required no hospitalization, and patients had significantly worse COVID-19 illness outcomes if they were taking rituximab or JAK inhibitors as compared to those taking TNF. Those taking abatacept and interleukin-6 inhibitors showed no worse outcomes than those that used TNF inhibitors. So moving on from the global registry, I asked the question, what treatment adjustments during this pandemic are needed in RA patients under the following clinical scenarios? So number one, RA patients without COVID-19 infection, whether it be stable RA, low disease activity, or in flare. And RA patients with ongoing COVID-19 infection, RA patients post-COVID-19 infection, and RA and vaccinations against COVID-19. And the sources of this, I specifically and purposely put them out, were the ACR, the APLAR, and the ULAR. And what's important to note is that the levels of evidence that were presented for these different guidelines or guidance documents were of low level of evidence. And a lot of them were, or most of them, were observational, retrospective, cohort studies, case controls, case reports, and even a lot of expert opinion. So this disease being very new and the data is being collected, and as we speak, and hopefully there will be more controlled studies and trials that will come out with regard to the use and treatment of the different rheumatic diseases, including rheumatoid arthritis during this pandemic. So it's an evolving, these are evolving manuscripts that change very often. And if you note, there's a lot of versions, they call them versions 1, 2, 3, 4, 5, depending on the latest information that comes up. So the APLAR in 2021, they came up with these general statements that patients with immune-mediated RMD may be at a higher risk for COVID-19 and of respiratory failure than the general population. Patients with RMD should be strongly advised to follow all preventive measures as stipulated by healthcare authorities in their countries as for patients without RMD. So this would be the same social distancing, wearing of or using of face masks and frequent hand hygiene. Patients with RMD should be tested as soon as they develop any symptoms of COVID-19 because of the potential increased risk of poorer outcomes. So risk, basically, it's been shown that they're the same risks that are involved. So increased age and a lot of comorbids, whether they be diabetic or having lung disease or hypertension. Those are the same risks. And of course, there are also risks with the use of their immunosuppressive medications and of course of the disease themselves. So RA patients without COVID-19 infection should be advised to continue their treatment unchanged, namely NSAIDs, glucocorticoids, conventional synthetic, targeted synthetic, and biologic DMARDs and analgesics, among others. This is ACR 2021, volume or version 3. According to current knowledge, there is no established association between a specific anti-rheumatic treatment and the likelihood of developing COVID-19. Please note that with the global registry, the risks were really, if you have the disease itself, the outcomes are poorer with use of your rituximab or your JAK inhibitors. In the absence of contrary evidence, patients with newly diagnosed rheumatic and musculoskeletal diseases without COVID-19 should be treated as per standard of care during the pandemic. And these are the different treatments that we mentioned above. And if you notice, the key recommendations for their use is basically they can be continued if you have a patient without COVID infection. And the second part of the sentence is usually to stop treatment once you have COVID infection. However, for glucocorticosteroids, patients who are chronically treated with steroids should continue their treatment at the lowest effective dose, even in case of SARS-CoV-2 infection, and you have to avoid abrupt withdrawal for fear of adrenal insufficiency. NSAIDs can be continued unless you have severe kidney, cardiac, and gastrointestinal injury. Anti-malarials can be continued, and once you have a definite infection, you can consider stopping this in case of chronic heart failure and or association with azithromycin because of the fear of an arrhythmia or prolonged QT intervals. Conventional synthetic DMARDs can be continued, but they recommend suspension of sulfasalazine, methotrexate, leflunomide in case of definite or suspected infection. Biologic DMARDs can be continued, and you suspend if there's infection. And according to ACR guidance, the very first version, anti-IL-6 inhibitors could be continued in selected circumstances of active COVID-19. And they suggest a more cautious approach pending better definition of circumstances and more consistent data on anti-IL-6 efficacy in COVID-19 treatment. Your targeted synthetic DMARDs can be continued with recommended suspension in case of definite or suspected COVID infection. So therapeutic options, alternative to rituximab, sulfasalazine, and cyclophosphamide, this is from APLAR, may be considered on a case-to-case basis. I think at the time that they came up with their guideline, there were some questions about sulfasalazine and cyclophosphamide actually giving the patient a higher risk for developing and poorer outcome for developing COVID-19 or once they develop COVID-19 infection. So I think this has been modified already, and sulfasalazine is not recommended to be stopped in patients without COVID infection. RA with disease flare without COVID infection. Flares of the disease may require the introduction of increased dose of glucocorticoids that are an established risk factor for COVID-19. And recently, moderate or high disease activity have been associated with a higher odds of COVID-19 hospitalization among patients with rheumatic and musculoskeletal diseases. A little bit more on glucocorticoids. Patients who are chronically treated with glucocorticoids should continue their treatment according to well-known good clinical practice of the lowest possible dose, even in case a patient manifests symptoms of COVID-19 infection. I think I mentioned this a couple of slides ago. And in terms of dose, the global registry COVID-19 study showed that prednisone of more than 10 milligrams per day was associated with a higher risk of hospitalization. Therefore, it is recommended to reduce the dose to less than 10 milligrams daily if the underlying RMD disease activity permits. What about RA with ongoing COVID infection? I already discussed this earlier. In case of documented or suspected SARS-CoV infection, regardless of COVID-19 severity, it is recommended to temporarily stop biologic targeted synthetic DMARDs, with the exception of anti-IL-6 receptor inhibitors that in selected circumstances could be continued, and immunosuppressants, azathioprine, cyclophosphamide, cyclosporin, mycophenolate, tacrolimus, should be discontinued in patients with COVID-19. This is from APGAR. RA patient post-COVID-19 infection, uncomplicated COVID-19 infections treated in an ambulatory setting, DMARDs and biologics may be restarted within 7 to 14 days of symptom resolution. For asymptomatic individuals, RMD treatment may be reintroduced approximately 10 days after diagnosis of COVID-19. Please note that I am using RMD treatment as an indirect guidance for rheumatoid arthritis patients. Reinitiation of treatment needs to be individualized for patients recovering from severe illness. So the Global Registry, Rheumatology Registry, once again, is doing a survey on COVID-19 vaccination. And just to show you the initial results for the COVID-19 GRA vaccine survey results. This is the largest international survey of COVID-19 vaccine concerns and outcomes in patients with systemic rheumatic diseases. There were 2,860 patients who completed the survey. Okay, this is the left side of this slide. Most patients, 80%, discussed vaccination with their healthcare provider. 90% were satisfied with the conversation. 67% were willing to pause medications for vaccination. And patients were most concerned about the risk of disease flare following the vaccination. The most common diagnoses and medications were one, rheumatoid arthritis, and the most common medication was methotrexate, followed by steroids. So the vaccine side effects were similar to the general population, regardless of the type of vaccine, which is good to note. Despite reported willingness, less than 30% of patients actually paused medications for vaccination. And 1 in 8 patients reported a disease flare after the vaccination, but the flares were usually mild, with fewer than 1 in 20 needing to adjust medications to treat the flare. Now for vaccine recommendations, and this is from the ACR Vaccine Clinical Guidance Summary. Their 5th version was published just this month, February 2, 2022. I just highlighted the rheumatology healthcare provider is responsible for engaging the RMD patient in a discussion to assess COVID-19 vaccination status and engage in a shared decision-making process to discuss receiving the COVID-19 vaccine. And a little bit down the line, beyond known allergies to vaccine components, there are no known additional contraindications to COVID-19 vaccination for patients with autoimmune or inflammatory rheumatic diseases. So this is a very clear statement that we have to vaccinate our patients. And this particular guidance for vaccine use also talks about the timing of giving your vaccine. So I have highlighted here rituximab as an example, which is usually given every 6 months, and it's recommended that the vaccine is given 1 month before the next dose of the rituximab treatment, if this is to be continued. With the thought that the different medications that are given will blunt the effect of the vaccine on the patient. And for all other conventional and targeted immunomodulatory and immunosuppressive medications, I'm going to include, let's say, methotrexate, which we use very almost in all our patients with rheumatoid arthritis. We hold for 1 to 2 weeks as disease activity allows, and after each COVID vaccine dose. So patients come first. Rheumatologists should explore the perceptions of patients and address their concerns to ensure treatment adherence during COVID-19 pandemic. The patient has so many fears about the risks of their getting infected with COVID-19 because of their disease or the treatment that they are receiving for their disease. So these are all valid concerns, and we must include this when we talk to our patients about their treatment. Telemedicine. During the COVID-19 lockdown, the implementation of telemedicine has dramatically increased and has proven to be feasible and effective for the online management of patients with rheumatoid arthritis. The use of telemedicine should be strongly encouraged, especially in areas of high community transmission, for follow-up of appropriate patients with RMD if implementing such an intervention is feasible and accepted by patients. And this we are all doing. So in summary, treat to target is still the main goal for RA, remission, or the low disease activity. Continue treatment in stable RA patients without COVID-19 infection. Rituximab and JAK inhibitors prior to onset of JAK-19 infection were shown to have poor outcomes and should be prioritized for risk mitigation strategies, particularly vaccinations. Stop treatment as recommended during acute COVID-19 infection. Know when to resume treatment, and vaccinations against COVID-19 are encouraged. So thank you very much, and special thanks to our fellows, Dr. Jen Magno and Dr. Noreen Garcia.
Thank you, Dr. Cervantes and Dr. Lorenzo, for the lecture.
Few questions that we want to address at this time. Specifically, the question on vaccination and methotrexate. One of our audience would like to ask, what is the worst that can happen if you give COVID-19 vaccine at a time when a patient is on methotrexate?
Okay, thank you for that question. Methotrexate is an anti-proliferative medication. So it means that methotrexate stops cells from replicating, and this can include T cells and B cells, which are essential for our immune system. No? just like what I discussed earlier, so it can blunt, being on methotrexate can blunt the formation of the antibodies against SARS-CoV-2. So the effect of the vaccine among patients on methotrexate might not be as well as those who are not on methotrexate. However, it does not say that it does not mean that there is no effect at all. There is still some effect, but it might be less.
Thank you. Let me again look at the question and answer chat box so that we can address the questions of our audience. Yes, Dr.
Dr. T,
Lorenzo.
can I
Sir.
just add to that? No, that the data on methotrexate is really based on previous data with influenza vaccine. And so the diminished response, the antibody response was noted with the use of methotrexate in patients receiving influenza vaccine. So it is an indirect evidence that it is applied also to the COVID-19 vaccine. Thank you.
Yeah, I'd like to pursue that, the observation of Dr. Lorenzo, because if we are looking at the influenza, what would be the effect of the platform? Because the platform for influenza vaccine is not the usual platform that is received by patients for COVID-19 vaccine, especially in the Western countries. Is there a similarity? Would you like to maybe discuss what if it's already an mRNA vaccine as opposed to the live attenuated type of vaccine? Will there be a difference for these vaccine types? What do you think, Dr. Cervantes or Dr. Lorenzo?
Well, all I can say is if it's a live attenuated vaccine, it still has not been approved for use in COVID-19, and I don't know if it ever will. So I don't know if the information, if we get information about the use of methotrexate and a different platform, will come up with the same results with influenza versus the COVID-19. So this needs more evidence.
Right. So inactivated pala, I was supposed to say inactivated virus, not live attenuated, because I was looking at the chat. So
okay.
What about that, Dr. Cervantes? Any comment on that?
Okay, inactivated vaccines are generally safe, no? As quoted from the PRA guidance, it is all there. They also use the IDSA 2013 recommendation that patients should be vaccinated with the inactivated flu vaccine, which I think has been a practice for many years now. And generally, even among patients with autoimmune and inflammatory rheumatic diseases, the administration of flu vaccine has been very safe and effective among this population of patients.
Thank you. One question from our colleague is there a limit to the dose of prednisone above which you can no longer give the vaccine? Because from our interaction with patients, she said that we hear some of our colleagues advising against the use of vaccine or administering vaccine when the steroids is above a certain level or a certain dose. Is there a limit to or a ceiling of steroid dose above which you can no longer give the vaccine?
Well, from my understanding, basically we try to bring down the doses of steroids, okay? But because of the blunting effect, However, as mentioned by Dr. Cervantes, there still is an effect if you get vaccinated. So the dose really of the steroid, what we have been advising is 10 milligrams or less to before the patient gets vaccinated. However, I think there's new information that even higher doses of steroids is not a contraindication to receive a vaccine. Of course, Dr. Cervantes can comment on this.
Sir, I've read some articles where they said that if the patient is on steroids with a prednisone equivalent of less than 20, then the patient can still proceed with vaccination. No, but I think the goal is really to bring it down to the lowest possible.
Yeah, I thank you for that answer. Yeah, it's generally 20 milligrams. That's why rheumatologists are doing their best to bring down the steroid dose, and we advise our patients on the proper timing for this. In the question and answer, our colleague Dr. Eunice Ko is asking, can you comment on the efficacy of Sinovac in preventing severe COVID among patients with rheumatic disease or those with DMARDs and without DMARDs? Have you observed any difference? And maybe in answering this, not just focus on Sinovac, but also on the other types of vaccine.
So sorry, but to tell you honestly, all the data I've seen were on mRNA.
So is there a difference if you're using the mRNA? O wala rin naman?
I suppose, sir, any vaccine is as good as the other in preventing COVID. I haven't really read data on inactivated vaccines in COVID and in room patients.
So I agree. The information really is mRNA, and so that's all that we can comment on. And I just agree that these mRNAs vaccines definitely help in preventing COVID infection and also lessen the risk of developing severe COVID.
Thank you. Our colleague also, no, Dr. Professor Hazel Reyes is asking and would like to know if we cannot lower our steroid dose to less than 20 milligrams, would you recommend a third dose or a booster dose? The difference being the dosage of the third vaccine. What would be a better way of doing things?
Based on the ACR February 2022 guidelines, they recommend a third, even a fourth dose, sir, for immunocompromised patients.
Thank you. Have you ever encountered patients who was in remission, maybe not just RA, lupus, and psoriasis, who after receiving vaccine developed disease flare? And to those patients, what would you recommend that they do?
I think that was mentioned in the survey. This was that survey of the GRA, that there were 1 in 8 patients who received the vaccine and developed a flare, regardless of what musculoskeletal disease they were dealing with. And the flares were mild. And 1 in 20 had flares that needed medication. So, and you treat the flare.
Thank you, sir. I think we don't have any more questions, and I'd like to, at this time, thank our speaker for their participation, for the lecture that really encouraged us to trust the vaccine and to know how to treat our patients at this time, take advantage of the development in telemedicine, and be able to still optimize the care of our patients despite the limitation of this pandemic. But hopefully within the next week, we'll have a lower level of alert system lower level here in the National Capital Region, if not in the whole country. Let's hope and pray that we overcome these challenges of the pandemic. And again, I'd like to thank you, and I'd like to invite our audience to the next LMLR that will be announced by the section of rheumatology soon. Magandang tanghali po sa inyong lahat.
Thank you.